Okay, there we go. Okay, so today's agenda, I'm going to talk about important factors when weaning off of GLPs, how to assess the patient after the medication. We'll learn about different medications that may contribute to weight loss resistance or weight regain. Talk a little bit about environmental substances that cause weight gain, and we'll discuss a few things that keep people stuck. So some important factors as patients are kind of trying to determine if they want to start weaning off the medication is to really determine why, right? Because that why is really going to be very, very different for many people. It could be because of expense. It could be because of side effects. It could be because of they're not having results. So really knowing that and digging into that is really gonna kind of change the course of kind of how you manage that patient. And we'll talk a little bit about that like after like down, few slides. But it's important to know what their current state of health is after the medication. So we're assuming that a lot of people are losing weight, they're getting into a healthier state, things are looking better, maybe they have weaned off of some of their lifestyle medications. So really assessing what their current state is before they go off on their own type of thing. So it's definitely best to titrate off of the medication. And this really can be different for many people. They don't have to titrate off of it, but we have found that patients do a lot better just because it is obviously titratable. So you want to almost reverse and bring them back down. There are some patients that just stop it cold turkey, which is fine. It's not going to be dangerous. The medication does stay in the system for approximately 30 days, but they do find, a lot of the cravings, the food noise, and things like that tend to come back really quick when they stop it abruptly, and they haven't, you haven't been able to actually assess where they're at before they stop it. So another important thing which we've talked about numerous times throughout these sessions is stressing the foundation. We always have to go back to the foundation. Are you sleeping? Are you handling and managing stress? Are you moving? And are you eating a healthy diet? I mean, it really always is going to come down to that because everything else will be temporary if there are some pretty significant missing pieces. So I call it the post GLP assessment or, assessing the patient, go back to their medical history form. I always go back to their medical history form so I can get an idea of because you tend to forget what other things the patient was dealing with, right? They could have had Crohn's, or they could have had a history of some significant history. So really refreshing your memory. And then as they are, as they're wrapping up, you probably would want to do another symptom assessment. We definitely do a final symptom assessment to see how that has changed. I mean, we're doing symptom assessments every month throughout their program, but then the final one and really assessing the beginning and the end is really telling. Looking at the medications and supplements, look at where's their body comp, their body comp now. Hopefully you'll have some of those metrics because again, I know it's not possible for everybody. I mean, nowadays it actually is because of like the home scales and things like that. But if you don't know what they've lost, it's going to be really, really difficult to assess their metabolic health because again, they could have been losing a lot of muscle, and without knowing that, it just, you're making a lot of assumptions that the weight loss was a healthy weight loss. You can ask for current labs. I talked a little bit about our metabolic health panel that anyone can do. It does not require, an MD or anything like that. It is a finger stick Sometimes we'll do that after a program just to kind of see where the patient is at, because I talk about this all the time, and I probably said it already a million times, but it truly is all about their metabolic health when they finish a program. That is going to dictate how resilient they are, to keeping the weight off. So just some things to think about the supplements. What supplements is the patient taking? Because I'm sure you all are working with patients that they are on just a garbage bag full of supplements, and they're not always healthy. A lot of them are full of junk. And so I think this is a really important piece to assessing as they kind of move on, with things on their own. I mean, and we're working with patients on their supplements the whole time, but I think it's always good to kind of regroup on, okay, what are you on? Because, people are buying stuff online, they hear something, they're grabbing it. So making sure they're on a good supplement regimen. Obviously looking at quality, if they have gut issues, oftentimes just the fillers and the dyes and the things that are in supplements could be contributing versus the food. You could recommend a supplement regimen that helps boost the GLPs. I know we talked about this in like a session, I think it was 2 weeks ago, but we will recommend a 2 or 3 different supplements, and we'll be sharing that with you guys because we put together like a semaglutide transition plan or GLP transition plan for patients. And then in there we have different supplements that we recommend patients use after. And we have gotten really, really positive feedback from that. And they'll often come back and continue those products. And then going back to their medical history and customizing their supplement needs. Do you need to work on, the gut, the sleep, are there other things that you can kind of tweak along the way? And do they need to stop taking some products, like Centrum or some of the crappier ones that people get from like Walgreens and Walmart? I'm sure we've all dealt with that. And everybody has their way of dealing with it. My way is that if somebody's on, a number of different supplements that are super poor quality, I will basically tell them that they're super low quality, and I will show them and, just show them why I'm saying it. And then I tell them, I'm like, it's up to you. If you want to continue the product, I don't want you to waste your money, continue the product, but then afterwards, let's get you on, a healthier alternative. So then they feel a little bit better because there's some sort of resistance when you're like, oh, you need to throw that away, and they're thinking they're wasting money, and that doesn't usually go well. And then you can educate them on Amazon, the dangers of retail. I mean, people are price shopping all the time. I'm sure most of you have like a full script account, so you can, make recommendations to your patients, but then they'll take your recommendations and then they'll go not troubleshoot, and go price shop. So what I ended up doing, and I feel like this helped so much, is in the full script protocol. So let's say I have a protocol for sleep management or whatever it might be. In there, the little write-up of that, I will add about the dangers of purchasing through Amazon, just because there are a lot of articles, and I'll connect to links that show that they've done studies on actual products, and they turned out to be just 100% like white rice or something like that. Not white rice, but some type of powder that wasn't even the supplement that it was claiming to be. So I think when we can just get that information out there, people are less likely to jump to Amazon and get their products there. Medications that are just problematic. Some more so than others. I can as I go through these, I'll tell you the ones that I just know every single time are always are causing issues. But here's the basic drug classes that tend to or can cause weight gain or weight loss resistance. Antidepressants, hormones, antihistamines, beta blockers, sleep aids, steroids, diabetic medications, mood stabilizers, epileptics, and antipsychotics. So we'll talk in a little more detail about this, but this is also part of that medical history, going back to your medical history and looking at the medications that they're on. And sometimes I'll even, at the beginning of starting somebody on like a GLP, I'll say, we're going to work with you on a lot of things, but I just want to make sure you know that, the medication that you're on, has been shown to cause weight gain. So we're probably going to go back to it. We're not going to talk about it now, but over time, I think it's going to be something important to circle back on. So that's why I do always go back and, just double check their intake form to make sure that there aren't any meds that may be contributing and holding them back as they transition out. So SSRIs, you can kind of see them all, the typical ones. I think Paxil is probably one of the worst ones. Cymbalta, venlafaxine, Effexor, I think those are less, that have less of effect, but they all can cause weight gain for various reasons. And then you have your TCAs. I haven't seen anybody on any of these, but these always tend to show up when we're trying to get newer research on medications that are contributing to weight gain. So antidepressants interact with acetylcholine and histamine receptors. So when these receptors are blocked, it can cause weight gain. There are numerous, kind of reactions that happen that causes it. But, I'm just kind of highlighting some of the main mechanisms. They interfere with serotonin. Obviously the serotonin or the neurotransmitter that regulates mood and appetite. So when serotonin is low, someone might experience more cravings for sugar and higher carb foods. These may trigger changes in metabolism that cause the body to use calories less efficiently, and they may increase blood sugar. And you'll start to see kind of a trend with these medications, and it's just like blows my mind because we all know that anytime you increase blood sugar, a medication increases blood sugar, you're automatically putting that patient at risk for more like foundational metabolic dysfunction. So it's really interesting when you start to dig deeper into some of the mechanism of actions. Hormones are a doozy for sure. So oral contraceptives, these Depo-Provera, IUDs, those, I mean, some people will even report gaining like 20 pounds within the first month that they start these. Now, not everybody is going to experience drastic results like this, but it is something to definitely be mindful of. These synthetic hormones. I mean, it's not even about the weight. If you're a hormone specialist, you already know how harmful these can be to the body, but they can cause fluid retention, increased appetite, and alterations in fat storage. So really promoting more of like the visceral fat storage, which obviously we all know is very bad. And then they also disrupt normal hormonal balance. So when you're taking these types of hormones, they will literally shut down some of your natural production of some hormones. So that obviously plays a huge role in metabolism and weight loss. Antihistamines are a big one as well. Like, actually, I'm getting ahead of myself, but these are some of the bigger ones. I don't see as much of an effect on like the capsules as much, because I do feel maybe it's because they're not on them all the time. We had this one guy that was took a Benadryl every single day with a glass of milk. So crazy. And we took him off of the Benadryl and the milk, and it was like insane. Like I think he lost, I don't know, he ended up losing like insane amounts of weight just from those two things. Histamine. So histamine affects the appetite control center in the brain, therefore blocking this receptor can increase appetite. So that's kind of how these can contribute. Well, and probably because they have major gut issues. And so that's often neglected if, you're being pumped with like antihistamines. Beta blockers reduce, so studies show that it reduces resting energy expenditure. It can prevent the pancreas from producing enough insulin. It reduces the thermic effect of food, reduces exercise tolerance by damaging the mitochondria. Love that, just like our statins. Increases fatigue, inhibits lipolysis, and can exacerbate insulin resistance. So some things that our little beta blockers can do. Sleep aids, oh my gosh, zolpidem, benzostrazodone. I see zolpidem. Am I saying that right? Zolpidem. I see that, and I see trazodone the most. And trazodone, it's usually people are slow at losing weight when they're on this. And then the second you get them on something more natural, then the weight loss starts to pick up. So watch for those. Sleep aids can cause weight gain due to increase in the patient's appetite and nighttime eating. It slows metabolism and just slows people down. A recent study on zolpidem showed an increased risk of type 2 diabetes. And melatonin, on the other hand, has been shown to have the opposite effect and actually improve hemoglobin A1C and blood sugars. So that's would be a good alternative. So steroids, we all know this, prednisone, hydrocortisone. Steroids can actually push you into diabetes. I mean, that's been shown over and over. So it alters the body's electrolyte imbalance and metabolism and can cause changes in fat deposition and increase appetite, increases your blood sugars, and can cause the liver to actually produce more glucose. So more gluconeogenesis is happening when patients are on these steroids. Diabetic medications, obviously this can contribute. We all know that insulin, is the fat storing hormone. We know that it allows more calories to get into the cells. So people with diabetes or medications can be contributing to the problem. Lo and behold, I know this is like just the big eye-opening problem to our medical system. We're trying to treat diabetes, but yet we give them something to offset all of the carbohydrates that they're eating and keep them in a very unhealthy overweight state. Hypoglycemia also can, as you all know, can cause overeating. Mood stabilizers. I haven't had a lot of experience with this, but they have been known to alter carbohydrate metabolism and cause fluid retention. In anti-epileptics, so gabapentin is common. A lot of people now are on gabapentin, and this has the propensity to increase appetite. It hasn't been one that I've seen cause a lot of problems, but again, it has been shown to be a culprit. So if you do have a patient that's been on it for a while and they're having a really hard time losing weight, that may be the reason why. Antipsychotics, these are kind of known for it. Clozapam, I can't even say those. I'm not really familiar with those, but the common antipsychotics that people are using definitely have multiple effects, like in the brain, hitting certain receptors, such as like serotonin, histamine, dopamine, adrenergic, and muscarinic. I can't say that one either. I'm not familiar with that receptor, but these have been, we've seen this quite a bit in our practice, that it really causes some weight loss resistance. Another thing to think about is, there's studies on every medication, obviously. The pharmaceutical industry does an incredible job at conducting research on all of the medications that they want people on. And nobody is really talking about polypharmacy. Nobody's ever talking about interactions of multiple meds. People are on 5 to 10, sometimes more medications at the same time. So we really don't know what that's doing to the body. We definitely know that lifestyle medications alter normal physiology. Whereas the GLPs, they do, they're more so in the line of mimicking normal physiology. I mean, there's nuances to that for sure, but it is very different than like a statin or a reflux, medication, that type of thing. So again, thinking about not only the one or two medications that someone's on, but it's the multiple concoctions that could be really putting the body into disarray. So I kind of already said it, but lifestyle medications, they do alter our normal physiology. We have to always remember that they are full of stuff. They're full of fillers, additives, preservatives, dyes, etc. So it's something that just has to be factored in, especially if you're working with somebody on their gut health and they've cleaned up their diet, looking really good. Why are they still having issues? And it could be because of the medications. So we all know I'm preaching to the choir, but these types of meds suppress the symptoms while the illness gets worse. Like I said, there's no known effects of combining multiple meds. Most medications, this is another really, really important thing that I think you can, really brush up on, is look at like the common medications that the majority of people are on, and look at the package insert or Google online to see what is the recommended time frame that people should, or what's the indication, what is the recommendation that people should be on it for a period of what period of time. And it will blow your mind. For example, uh, proton pump inhibitors, so medications for reflux, they recommend that the patient stays on it for 2 to 4 weeks. Patients are on these meds for 10 years. So again, I mean, I know there's a lot of things to look at, but when you kind of hone in on the common lifestyle meds that people are on, that is going to go a long way when you can start to have those conversations about, you need to talk to your doctor about this. You need to ask them why they think that you need to be on this for this long of a period of time, when really it clearly says I should only be on it for 2 to 4 weeks. So something to think about. People really don't need, obviously, these medications. 80% of all chronic diseases are preventable. And we we do have discussions with our patients about the medications. I do a lot more of that than my employees, because I feel more comfortable having those conversations. I think I say this all the time. I never ever recommend or tell anyone to stop taking anything. I tell them to go to their doctor, empower them, be prepared, go in with the right questions and see if you can come up with a plan to start weaning off of it. So that's kind of how that goes. Now, I will say that some patients are at a point where they're so fed up with their doctor and they'll do what they're going to do anyway. I'm going to look at a question. Okay, so Karen says, I've had good luck contacting patients' doctors, asking them to partner with weaning off some of, yes, exactly. Exactly. So really having that be a collaborative effort, because I think we hear it all the time. It's kind of like, if you didn't prescribe it, you definitely should not be telling people to go off of it. And I firmly believe that, even though I don't believe in what they're taking, I would never cross that line with people or doctors. Okay. I'm gonna go through this pretty darn quickly. It's again kind of like a little bit of just a reminder that we really need to be having these discussions with some of the environmental stuff because it is what is causing the metabolic dysfunction that we have right now, which is pretty much 100% of people. So obesogens, obviously is a term that has been coined because now there's studies showing that these toxins do cause obesity. So they're chemical compounds that affect normal development and function of lipid metabolism and the endocrine system. So endocrine disruptors you probably heard about. They alter fat storage, they alter the set points of someone's weight, and they disrupt energy balance. They modify the appetite regulation. They put major strain on the liver, and they basically obviously pollute the body. They're everywhere in our environment. They're in our food and water, in the toys, our cookware, cleaning supplies, personal care products. And we all know this. So, it is really about honing in on the low-hanging fruit because it truly is everywhere. So what do they actually do? Studies show, because I've read a number of different studies because I wanted to know if what they were truly doing. I know it causes toxicity in the body and fatty liver and all of that, but so studies show that they increase the number of fat cells, they increase the storage capacity in the fat cells, they shift the energy balance to more energy storage. So that in itself is visceral fat. When you're pushing uh, calories into store, it's usually going right into the visceral, which becomes immediately inflammatory. It alters our metabolic rate, as you can imagine. It kills our microbiome. We know that leaky gut increases our risk of insulin resistance. So it's that whole cascade that's happening. And then it modifies our hormonal control because of appetite and satiety. So it's kind of like it's breaking us down, it's hitting the foundational issues, and so now the body's in total disarray, and we're consuming these things on a regular basis. So the top 5 obesogens are BPA, phthalates, pesticides, and herbicides, PFOA, I won't try to say that one either, and organotins. So these are the top 5. And I've you can, if you're interested, you can kind of see where they are located. I mean, I kind of have a couple slides on them, but BPA is huge. I mean, they're doing studies and looking at how much BPA people have in their body, as well as newborns. And they're showing that, newborns are just full of plastic. So that's scary. So it's also, in our foods, we have obesogens in our foods. Growth hormones are now put in many, our dairy. You can kind of see how puberty has changed over time, how the size of people have changed over time. Typically, and this is just a pure opinion and things that I've experienced over the years, but people that were big milk drinkers, like kind of into adulthood, have so many problems, and they're just so many more problems, I should say, and they're just big people, because of probably all the hormones that they've been consuming all these years. Antibiotics are in our foods. That is pretty common. High fructose corn syrup is everywhere. And then many food additives, obesogens are this is not regulated by the FDA. And I think you all probably saw that the FDA finally banned Red 40 dye. Was it Red 40 dye? And now we're starting to see some things that they're recognizing. I think there was something recently, a moisturizer that they banned from the market now. And it seems a little suspicious, in my opinion. I know there's going to be changes. I mean, there's going to be massive changes with the government shift and things like that. But these products are shown to not only cause obesity, but they're clearly shown some of them to cause cancer as well. And they're everywhere. They allowed it. Our government has allowed that. So, and then you have our tap water, which I'm assuming nobody really promotes tap water, but there's heavy metals that leach from the pipes. Modern plumbing is made of PVC, which is a major, major obesogen. Fluoride is very toxic. It's also a goitrogen, so it lowers iodine. We've learned that in school. And fluoride can be a major obesogen as well. And so not only that, it just can be very harmful to the brain. I do believe fluoride's one that can pass the blood-brain barrier. So these are things, again, that are touted healthy. So we're consuming it. I was just at my last dentist appointment. She's like, "Do you want a fluoride treatment?" I'm like, "No, please." So just again, some things to think about. So metabolic dysfunction absolutely starts with blood sugar dysregulation, blood sugar dysregulation, probably some gut stuff going on at the same time, and then this cascade of events begins to happen. But it's not just about that. Like, this is truly the perfect storm. There's multiple things that have led to the state of health that that humans are where humans are at to this day. And truly it is because of all the toxins in our environment. So toxins are mainly lipophilic. So they will accumulate in the fat tissue. I mean, they can go anywhere. They can go in our joints, they can go in our brain, they can find their way in our throat. I mean, you'd be surprised where, these toxins can find themselves. I mean, it really does depend on if they are more hydrophilic or lipophilic. And so the visceral fat obviously tends to be that main dumping ground for toxins. And it is one of the main reasons why the visceral fat becomes unaccessible when someone is trying to lose weight, because it's, again, that protective way the body protects itself because of the toxic nature and the inflammatory nature of the visceral fat. So I know we talk about mobilizing fats all the time, but a lot of people are very familiar with the keto diet, and you hear it's very common knowledge about people that are on the keto diet that can experience the keto flu. And that is exactly what's happening, because you are breaking down those fat cells, you're mobilizing the fat cells, and all of those toxins come into circulation. And your body has to be able to handle that. And most people can't handle it. So they may think like, "Oh yeah, I mean, I'm releasing all these toxins." But if your liver and your gallbladder and your gut, if those systems are not working optimally, you're going to reabsorb it right back in. So it's so important that we are that we're really acknowledging the presence of these toxins. And as people lose weight, especially if they're like on like a quicker fat loss plan, we have to be able to kind of talk them through and manage the toxic load. Like I said, toxins can recirculate, and they can find their way in other parts of the body. So again, liver health is probably the most important, but obviously gallbladder as well. But as you know, most people don't even have gallbladders. So now the liver takes on that role as well. So it's already in a compromised state. So something to keep in your back pocket. All right. So what we'll do when we're really trying to dig deeper with patients that are just brain fogged, they're a mess, right? So you have to look at their habits, because we're human, right? I mean, this is the life that we live, but just try to identify habits that are probably bringing them down. And because it can start, it can be overwhelming, from your bedding, or your sheets that you're breathing every night, your toxic laundry detergent, which is just terrible. The cleaning supplies, right, there's 8 toxins hiding in your cleaning supplies. I mean, cleaning supplies are ranked up there as really one of the worst that are affecting people. And then our toothpaste. you know? I mean, it is kind of crazy that on toothpaste that we give to children, it says, do not swallow, adults and children 2 years. Um, oh, and call the poison control center if swallowed. Uh-huh. All right. So we're having kids put this in their mouth, but yet we're writing a disclaimer on the label saying that they need to have contact poison control if the kid swallows it. I mean, this stuff just, you can't make it up. Okay. Shampoos and conditioners are terrible. So identifying, I mean, I've created like a bunch of protocols for certain areas because patients get overwhelmed. And what you can do, which I found to be pretty helpful, is in Full Scripts, if you guys have an account, just create a clean product list and send it to your patient and they can start there. And that usually, and they love that. So then saves them like just a ton of time. Makeup, another big problem. I love that there's so many new companies, cleaner companies coming out. And I truly believe that it's going to be so different in years to come. 5 years, I think that we'll start to see effects from kind of companies starting to change things because of the change in government and RFK and all of that, because they're all over this. And they're going to bring awareness to it. So there's companies that are afraid and they're going to start making some changes. So again, I think we still have to be aware of it, but I'm optimistic. If you're working with kids, oh my gosh, Coffee Mate, absolute poison. I mean, all of these products. So again, just maybe identifying certain things, milk drinkers, just identifying certain things that you can start small with people. Air fresheners, terrible. Friends don't let friends use toxic air fresheners. That is me. And some people get really mad at me, but if I go in anywhere I go, I will unplug it. I mean, I try to be nice and try to explain it, but I said they could plug it back in when I leave, but they're that bad for you. So just think of the people that are, consuming this stuff day in and day out. That is causing metabolic dysfunction. Water, I don't think I have to say much more about that. Just watching for people that are chronic water bottle drinkers, easy fix, get a glass bottle or get stainless steel. It can resolve a lot of those problems. So signs of toxicity, we all use this because I feel like this is probably a symptom assessment that we're all utilizing. But again, just something to, again, go back to when someone completes a program so you can kind of see if there's still some like sluggish liver symptoms, things that may contribute to weight loss resistance. So some supportive supplements that we will help our patients with or recommend to our patients after a program is definitely liver support. That you can there. I don't think there's anyone that shouldn't be on like some sort of liver support product. Blood sugar and insulin support. So that would be like your GLPs, and we'll be giving you guys like the recommendations that we use. We use the alpha lipoic acid, berberine. We use a product for cortisol because everyone has, cortisol dysregulation. Mitochondria support is huge. The cells are inflamed. It just depends on how much cellular inflammation someone has, but we really do have to support the mitochondria because it's been through the rigor. For sure. Gut health support, and then any type of stress or sleep support. Those are like the common ones that we're recommending to most people. And then the diet. So this this is how we approach the diet when somebody finishes a program. We first have to assess what's going on after. We have to kind of look at those multiple things, we basically say we assess your metabolic health. So we're looking at your visceral fat, we're looking at your symptoms, we're looking at lean body mass, muscle mass. So that to us is a good picture of metabolic health. And so if they're still metabolically unhealthy, we will lower their carbohydrates for a period of time or recommend that they do that. If they're pretty strong and they've done all the things and they feel great, and they want to incorporate more carbs, we absolutely will allow them to, obviously they want to still continue to eat clean, but they'll eat a good amount of carbohydrates in their diet. Obviously, clean eating is going to be huge. We do a lot of intermittent fasting when people go off on their own, if it works for them. And that warrants a conversation, and we can talk more about that if you guys want to. But I do think it's an awesome way to get people to reset their body, their biochemistry, because so many people are used to putting something in their mouth all day long. And when you put something in your mouth all day long, even if it's healthy, you are shutting off the fat burn. So people are we're really trying to train them to either just have 3 set meals and just stop the snacking in between, or we will, like I said, we will do intermittent fasting. People seem to like that. Okay, so if calorie counting, be careful, as metabolism has changed over time. And again, the muscle and the fat. So what I mean by this is, if you're using calculations, we will get a basal metabolic rate from our body composition scale. And the BMI, so the basal metabolic rate is really calculated based on the patient's lean body mass and muscle. So we feel that it's a pretty accurate number. And so let's say that I was using like old school Harris Benedict or something like that. I don't know what people are using now, because we've just been using, this our InBody for so long. But what I can tell you is the BMRs are so off, because let's just say, somebody finishes a program and they still have, I don't know, let's just say they have 20 pounds to lose yet. And let's say their BMR is 1450, and the recommendation is to add more calories to that, because the basal metabolic rate is what your body uses at rest, and then you ramp it up to, what, 1800 calories. That's the recommendation. We never do that. People's metabolism is totally changed. So if we actually will recommend people stay close to their BMR, start there, see how they feel, see how they respond, and then slowly they can start, adding calories back in, different foods, just because you have to really pay attention to how the body's going to respond to that. So again, I know this can go in many different directions, but I think just in general, people need to be on much lower calories because of our metabolic health. Okay, so you will find a transition booklet in the platform, and it's really great. It goes through many different recommendations of get a meal plan, and then it goes through different supplements that we recommend. And you can kind of see just a snapshot of that. We private label our supplements. What I'll have to do is give you a name of something that might be similar. So, okay. So strategic weight loss, I am going to this is one slide, and I wanted to touch on it because there were many questions on strategic weight loss, and then the surveys that were completed, people were asking questions about strategic weight loss. Okay. So just in summary, I created a 30-day program called Strategic Weight Loss, because I wanted to accomplish a lot of things during 30 days, because just lowering calories, exercise more, like none of that works. So I knew I had to accomplish multiple things. So I had to support detoxification. I had to target the visceral fat because that does not, your body won't really just regularly go to that in a calorie deficit. The diet had to be calorie restricted because at the same time we were mobilizing the fats into the mitochondria. So so I had to create a calorie deficit at the same time so the body would go to those fat stores. So hopefully that makes sense. So at the same time as you're mobilizing fats, the body was looking for calories because we created like that calorie deficit. So the meal plan is lower calorie. It's very clean. It's no carbs and no fat actually as well. And it's crazy what it does to the body. But the meal plan also excludes obviously inflammatory foods. So all of these things being done at once is kind of a complete game changer for people as they go through this. So they're following a structured plan, and then we're giving them a a number of different supplements. We have 3 different programs, so we have two that we're sticking to right now, and they have 3 different supplements in each set. So depending on what their goals are, that's the one, kind of we recommend to people. I won't really go into the details about that, but they're all quick weight loss. They're all designed to get the body in a healthier metabolic state. Okay, so maintenance support, kind of thinking ahead how you can support your patients long term, how they can stay accountable to you and connected. Do you want to do just regular visits, like monthly sessions? Do you have a way to access like their food logging? How will you monitor their body composition changes? What we do often with our patients is we set them up for like 2 to 4 of our strategic weight loss programs per year. So every quarter they'll do like a reset, and that kind of keeps them on track all year round. So hopefully that makes sense. Okay, so in summary, when a patient is finishing up, you want to know where they're at. Kind of regroup on their medical status. Clean up their meds as needed and supplements, again, meaning talking to them, how they can work with their doctors, identifying regular habits that are sabotaging their health. To give you an example, I was working with this one woman, very, very sweet. She had so many gut issues. Later turned into she was diagnosed with Crohn's. They were checking for cancer, and she was young, but she was a mess. But she would work out every day. So I always felt like, gosh, she's trying so hard to get better, and she just can't get a break. And then I'm reading through like some of her notes, and it says that she drinks a big gulp from McDonald's every single day, and she's been doing that for like 20 years. And I'm like, so like sometimes they don't tell us things that could be the complete game changer. So obviously we had a discussion about that. I mean, I'm not saying that that was the only thing that caused all of this, but I was working with her for over a year, and it would have been nice to know that. Um, Make sure patients, and you guys know a lot of this stuff, but make sure they understand that, in order for change to happen, they have to make some changes. It's just, I laugh because we get the question, and I just had another question not even too long ago about, so you're saying that I could gain the weight back after I stop this medication? Yeah, yeah, you can. If you're not in a healthier state and you don't make the appropriate changes, like people still think it's just going to stick. So reinforce the foundations, and then have somewhat of a maintenance plan ready to go for them. So because most people, they want something, and that's just going to keep you connected with that person. All right, so next steps are okay, so we have one more session here where we're talking about the future of GLPs. And then we're right now putting together 2 other courses. One is called the Foundations of Functional Weight Loss, and one is where we dig into more details about strategic weight loss. We are going to start a GLP membership, or I'm sorry, a mentorship. So you can get assistance whenever you need. And then we're gonna continue our RD discussions, but we are gonna do those quarterly rather than monthly because it was just so much for us. And so that's the plan there. And I did want to just mention a couple things before I open it up. I sent you all a survey for the course and I did get quite a few back, and I really, really so value the feedback because we do want to improve this. We understand that there is massive room for improvement. The other thing I wanted to mention is that I would love if you guys would be interested in writing a recommendation through LinkedIn, if you feel that it would be a positive recommendation. So how that would work is I would notify you through LinkedIn, and I have to, I guess, I have to be first connected with you, so I have to friend you, and then I can request a recommendation. So if you feel you could give a few words about the course, that would be amazing. And then anyone that you refer to us, we give you a $75 credit for anything. So that can go toward any of the future courses or a mentoring session or anything like that as well. So that's it. Hopefully I didn't go too far over. Okay, so any questions?
Hi, Sherry, it's Abby. I have a couple of questions.
Yes.
Yeah, thanks. This has been great. Learned a lot, super great stuff. Fits right in with some of the stuff that I'm starting to do. I have a client who is starting to her weaning off. And she's been a client of mine. She's a binge eating disorder history client. And she's actually been doing really well. And she's freaking out a little bit because she's worried about the food noise coming back, right? But also I'm curious as to what you say. Her family, like her husband and her kids, eat like crap, and they refuse to change. I mean, her husband is so sick, but he doesn't care. He just keeps eating the crap, and she's trying to change, but she's got this whole history, binge eating, and they don't eat well. And I've had a couple, the last sessions have been a little bit more of this come to Jesus moments of like, this isn't going to work for you as you're weaning if you don't clean up your diet. And she's like, well, I can't afford to buy separate food than my family, and I am like, can you transition them a little bit? And, or can you start adding things in? I don't know if you've run into that. So I'm just curious if what your experiences have been with that and your thoughts on that.
Yeah, I mean, it really, really is a difficult situation because you truly don't know the dynamic, and the dynamic can be so deep, or it could be relatively like a simple fix. So did you say that there's kids in the house?
Yeah, there's one who's an adult who only comes back here and there, lives with them sometimes, but or he's older. And then she's got like a 13-year-old.
Yeah, so and again, I already know what you're going to say after this, but basically what I would say to that person is, this is her life, right? So she has the ability to do what she feels she needs to do. And she has a minor child. She can start cooking. She can't control what her husband is going to eat. And yes, he's going to influence and probably negate like a lot of things. But over time, if she continues to cook healthier, it starts to rub off on people. And we do see this. She starts feeling better. Then the husband's kind of like, kind of awakening to some things. So I would just, I mean, just off the top of my head, is tell her to stick to what she feels is right to do that for her health. And you can't worry about the husband. Because it is one of those things where if you wait for the support, then that will never happen. And then you're going to end up exactly where you were. She needs to focus on herself and the kid. Because, and I talk about the kids too. I had a similar situation not too long ago. And at the end of the day, like her kids are going to be dealing with the same issues that she's dealing with if she doesn't get a hold of it sooner rather than later.
Yeah, that's helpful. Thank you.
I mean, and if anyone else has any suggestions, I mean, Abby, it is absolutely a difficult situation. And you know what I always do too, which is really helpful. I put it on them. I will say, and this is kind of what I do about everything when I'm helping with goals. It's like, what do you think you can do? What do you think is within your capacity? Let her think about that. Really dig deeper into that because all the answers she has all the answers. She just needs to kind of work through it. You know what I mean?
Yeah, absolutely. Yep.
I think someone wants to chime in here. Let's see. Yeah, so Karen says this is a great place to talk about setting boundaries and a great place to loop in counseling. Exactly. Boundaries is perfect. I think that would be like almost the best way to start because you're not getting deep into the woods quite yet. You're kind of setting what is that main thing that needs to be set right off the bat that will be the slippery slope that sends her down the same track. So, does anyone else have any